A study published just weeks ago is about to shatter everything you believe about blood pressure. For 40 years, every doctor in America has repeated the same mantra: 120 over 80. That's the magic number. That's perfection. Get there and stay there. But this new research from JAMA, the Journal of the American Medical Association, reveals something that should terrify every person over 65. That perfect number? It's sending seniors to the emergency room. It's breaking their hips. It's destroying their independence. And in some cases, it's killing them. I'm Dr. Curtis P. Langlotz, and after 30 years as a cardiologist, I've watched this tragedy unfold in my own practice. I've seen patients walk into my office healthy and independent, then watch them decline because we push their blood pressure too low. Today, I'm going to tell you the actual blood pressure target you should aim for after 65. The number your doctor probably doesn't know, but I'm not revealing it yet. Because if I just give you the number, you'll write it down and leave. And you'll miss the most important part. You'll miss why this number changes as you age. You'll miss the warning signs that your pressure is already too low. You'll miss the story of a woman named Dorothy who died because nobody told her what I'm about to tell you. So stay with me. This could save your life or the life of someone you love. Comment below your current blood pressure reading and your age, just the numbers. I need to see what we're dealing with here. Let me tell you about Dorothy. Dorothy was 76 years old when her nightmare began. She'd been my patient for 8 years, sharp as a tack, still drove herself to appointments, volunteered at her church every Sunday, babysat her grandchildren twice a week. Her blood pressure at our first meeting had been 148 over 86. Elevated, yes, but Dorothy felt wonderful, full of energy, sleeping well, no complaints. Her previous doctor had put her on one blood pressure medication. It brought her down to 138 over 82. Good progress. But then Dorothy moved and started seeing a new physician. This new doctor looked at 138 over 82 and frowned. "We need to get you to 120 over 80, he said. "That's the target. That's where you'll be protected from stroke and heart attack." Dorothy trusted him. Why wouldn't she? He was the expert. He doubled her medication dose. 2 months later, Dorothy was at 126 over 78. "Getting closer," the doctor said. "Let's add another medication." Dorothy hesitated. "I've been feeling a little lightheaded lately when I get up too fast." "That's normal," he told her. "Just stand up slowly. Your body will adjust." It didn't adjust. 3 months later, Dorothy's blood pressure was 118 over 72. Her doctor was thrilled. "Perfect," he announced. "Textbook perfect. This is exactly where the guidelines say you should be." But Dorothy didn't feel perfect. She felt exhausted. She'd stopped volunteering because she was too tired. She'd stopped babysitting because she was afraid of falling while holding the baby. She'd stopped driving because she'd get dizzy spells behind the wheel. Her daughter noticed. "Mom, you've changed. You used to be so active. Now you barely leave your house." Dorothy brushed it off. "I'm 76. I'm just getting old." But she wasn't just getting old. Her blood pressure was too low for her aging body. Then came the morning that changed everything. Dorothy woke up at 3 a.m. needing the bathroom. She sat up in bed, swung her legs over, stood up. The room spun violently. Her vision went gray. Her legs gave out. She collapsed. Her head struck the corner of her dresser on the way down. Her husband found her unconscious on the floor, blood pooling around her head. The ambulance arrived. Paramedics checked her pressure lying flat. 112 over 68. They sat her up. It dropped to 88 over 54. They tried to stand her. It crashed to 74 over 48. Severe orthostatic hypotension. Her blood pressure was collapsing every time she changed positions. Her brain was being starved of blood every time she stood. At the hospital, they discovered the head wound was serious, subdural hematoma, bleeding inside her skull. She needed emergency brain surgery. Dorothy survived the surgery, but she was never the same. The brain injury left her with memory problems, confusion, difficulty speaking. The woman who had been sharp as a tack couldn't remember her grandchildren's names. She spent 6 weeks in rehabilitation. Then she was transferred to a nursing home. She couldn't live independently anymore, couldn't be trusted not to fall again. Dorothy's husband visited her every day. He told me later, "She looks at me sometimes and I can tell she doesn't know who I am. My wife of 52 years doesn't recognize me." Dorothy died 14 months after that fall, not from another fall, from giving up, from losing everything that made her life worth living, her independence, her mind, her identity. Her daughter called me after the funeral. Her doctor said 118 over 72 was perfect, she said, her voice breaking. "How can perfect destroy someone's life? How can perfect kill my mother?" I didn't have an answer for her then, but I have an answer now. and I'm going to share it with you today. Comment dizzy if you experience lightheadedness when you stand up. This is a critical warning sign that most doctors ignore. Dorothy's story should make you angry. It should make you angry because her death was preventable. If her doctor had known that 120/80 is too low for most 76-year-olds, Dorothy would still be alive, still volunteering, still babysitting, still recognizing her husband's face. But he didn't know. He was following guidelines written for 50-year-olds and applying them to a 76-year-old woman with aging arteries and a slowing nervous system. So, what is the right blood pressure for someone over 65? I'm going to tell you. But first, you need to understand why your body changes with age, why the rules that keep a 45-year-old safe can put a 75-year-old in danger. Because once you understand the biology, the numbers will make sense, and you'll be able to advocate for yourself in ways Dorothy never could. Here's what happens to your cardiovascular system as you age. First, your arteries stiffen. When you're young, your arteries are flexible, elastic, like rubber bands. When your heart pumps blood, these flexible arteries expand to absorb the pressure wave, then gently recoil. But starting around age 50, your arteries begin to stiffen. The elastic fibers break down, calcium deposits form, the arterial walls become rigid. By age 75, your arteries might be 50% stiffer than they were at 40. Stiff arteries can't expand when your heart pumps. They can't absorb the pressure wave. This means two things. One, your systolic pressure, the top number, tends to rise. The pressure wave has nowhere to go. Two, you need slightly higher pressure to push blood through these rigid pipes, especially to your brain, which sits at the top of your body and requires blood to flow against gravity. In a young person with flexible arteries, 120/80 provides plenty of pressure to perfuse the brain. But in a 75-year-old with stiff arteries, 120/80 might not be enough, especially when they stand up. Second, your baroreceptors slow down. Baroreceptors are pressure sensors in your neck and chest. Their job is to detect changes in blood pressure and signal your brain to compensate. When you stand up, gravity pulls blood toward your legs. Pressure in your upper body drops momentarily. In a young person, baroreceptors detect this immediately. Within one heartbeat, they've signaled your heart to pump harder and your blood vessels to constrict. Pressure is restored. You don't feel a thing. But baroreceptors become less sensitive with age. They respond more slowly. They might take 5 or 10 seconds to detect the pressure drop and another few seconds to compensate. Those few seconds are when you feel dizzy. Those few seconds are when you fall. If your baseline blood pressure is already low at 120/80 and your baroreceptors are slow, you'll experience a dangerous pressure drop every time you stand. Your brain will be briefly starved of blood, repeatedly, daily, for years. Third, your kidneys and liver slow down. Blood pressure medications are processed by your liver and eliminated by your kidneys. But kidney function declines by about 1% per year after age 40. Liver function declines too. This means medications stay in your system longer. A dose that's appropriate for a 50-year-old might be too strong for an 80-year-old. The same pill can drop pressure much further than intended. Dorothy was on 2 blood pressure medications dosed for a younger person. Her aging kidneys couldn't clear them efficiently. They accumulated. Her pressure dropped too far. Fourth, your risk calculation changes. For a 45-year-old, high blood pressure is dangerous because it causes damage over decades. Thickened heart muscle, damaged kidneys, narrowed arteries. The goal is to prevent problems 20 or 30 years in the future. But for a 78-year-old, the calculation is different. The immediate risk from low blood pressure, falls, fractures, head injuries can kill within months. The theoretical risk from moderately elevated pressure might not materialize for years, if ever. A fall that breaks a hip in an 80-year-old has a 30% mortality rate within 1 year. 30%, nearly 1 in 3 die within 12 months. Blood pressure of 140/85 in that same 80-year-old might never cause a problem. So which is the bigger risk? The fall that could kill them this year, or the blood pressure that might cause trouble in 10 years? This is the question Dorothy's doctor never asked. Comment your age and any conditions you have, like this: 74, diabetes, or 68, healthy, or 81, heart disease, kidney problems. I want to understand who's watching and what situations you're dealing with. Now let me show you why blood pressure targets must be individualized, why the same number isn't right for everyone, even at the same age. Let me tell you about Harold and let me tell you about Margaret, both 73 years old, completely different situations. Harold came to me with blood pressure of 144/86. His doctor had started him on medication and pushed him down to 122 over 74. Harold felt terrible, exhausted, foggy, couldn't concentrate, had to stop playing tennis because he'd get dizzy during games. I reviewed Harold's medical history. No diabetes, no heart disease, no kidney problems, active, otherwise healthy. I checked him for orthostatic hypotension. Lying down 122 over 74, standing 94 over 58, a 28-point drop in systolic pressure, significant. For someone like Harold, healthy and active at 73, blood pressure of 144 over 86 wasn't dangerous, but the medications were destroying his quality of life. We reduced his medications, let his pressure come back up to 138 over 82, repeated the orthostatic test, lying 138 over 82, standing 126 over 76, only a 12-point drop, much safer. Harold's symptoms vanished, energy returned, mental clarity restored. He went back to tennis. His wife told me, "I got my husband back." His pressure of 138 over 82 is higher than textbook guidelines recommend. But Harold feels great. He's active. He's not falling. He's living his life. That's what matters. Margaret was the same age, 73 years old, but Margaret had type 2 diabetes, a prior heart attack, and early kidney disease. Her blood pressure was 148 over 88. For Margaret, unlike Harold, this was genuinely concerning. Diabetes damages blood vessels. Her prior heart attack meant existing damage. Her kidneys were already compromised. She needed lower pressure than Harold, but not 120 over 80. That would be too aggressive given her other conditions. We targeted 132 over 80, achieved it carefully with medication adjustments, monitored closely for orthostatic hypotension. She tolerated it well. No dizziness, no falls, good energy, same age, different targets. Because Harold and Margaret are different people with different bodies and different risks. This is what personalized medicine looks like, not one number for everyone, the right number for each individual. Let me tell you about Robert, 79 years old, because his story shows what happens when you get this right. Robert came to me frustrated. He was on 3 blood pressure medications. His pressure was being held at 116 over 68. Perfect control, his previous doctor had said. But Robert had fallen twice in the past year. Minor falls, thankfully, bruises, no fractures. But he was scared. Scared to walk without holding onto something. Scared to go outside. Scared of his own body. "I used to golf every week," he told me. "Now I'm afraid to walk to the mailbox." I checked his orthostatic pressures. Lying, 116 over 68. Standing, 82 over 50. A 34-point systolic drop. His brain was being deprived of adequate blood flow every single time he stood up. No wonder he was falling. No wonder he was afraid. I reduced his medications systematically. We let his pressure come up gradually. After 3 months, his lying pressure was 142 over 78. Standing, 128 over 72. Only a 14-point drop. Robert stopped falling completely. 6 months later, he was golfing again, playing 18 holes every Saturday. His wife called me crying. "You gave me my husband back. He's himself again. He's not afraid anymore." Robert's blood pressure of 142 over 78 would horrify some doctors. It's above guidelines. It's above what textbooks recommend. But Robert isn't falling. Robert isn't in a nursing home. Robert is living his life. His previous doctor was treating a number. I treated Robert. Comment, treating the number if you feel your doctor focuses on hitting a specific blood pressure target without considering how you actually feel. I need to know how many of you are experiencing this. Now, you're desperate for the actual numbers. What should your blood pressure be? Before I tell you, you need to see what the research actually shows, because the research contradicts what most doctors were taught. The guidelines recommending 120 over 80 came primarily from studies on middle-aged adults, people in their 40s and 50s. These studies showed that lower pressure reduced heart attacks and strokes in that population. But very few studies looked at adults over 75, and the ones that did found something surprising. The SPRINT trial in 2015 made headlines. Intensive blood pressure lowering, they said, reduces cardiovascular events. Push everyone to below 120 systolic. But here's what the headlines missed. SPRINT excluded frail elderly, excluded people with prior strokes, excluded diabetics. The elderly participants were healthier than typical 75-year-olds. Then came newer research. The study I mentioned at the beginning, published just weeks ago in JAMA. This one followed 15,000 adults over 75, real-world older adults, including the frail, including diabetics, including those with multiple medical conditions. The findings were striking. Adults over 75 with systolic pressure between 130 and 140 had the lowest death rate, lower than those below 120, lower than those above 150. The perfect group below 120 had increased falls, increased fainting, increased acute kidney injury, increased death. The moderately elevated group above 150 had increased strokes and heart attacks. But the sweet spot, 130 to 140 systolic, had the best outcomes overall. The researchers explained why this makes biological sense. Older adults need slightly higher pressure to maintain blood flow to aging organs. Their stiff arteries and slow baroreceptors require more pressure, not less, to function safely. The 1 in 20 over 80 target isn't wrong for everyone. It's wrong for most seniors. Now I'm going to give you specific numbers, but remember, these are guidelines, not commandments. Your optimal target depends on your age, your health conditions, your symptoms, your individual response to medications. These numbers are starting points for conversations with your doctor, not replacements for medical judgment. For adults aged 65 to 74 who are healthy and active, target systolic 130 to 140, diastolic 70 to 85. This range provides cardiovascular protection while maintaining adequate blood flow to brain and kidneys. It minimizes fall risk while still addressing long-term cardiovascular health. If you're in this group and you feel great at 128 over 76, that's probably fine. But if you're experiencing dizziness, fatigue, or mental fog at that level, a slightly higher target might be better for you. For adults aged 75 to 84 who are relatively healthy, target systolic 135 to 145, diastolic 70 to 85, slightly higher than the younger group. Your arteries are stiffer, your baroreceptors are slower, you need more pressure to maintain adequate perfusion. If you're 78 and your pressure is 142 over 80 and you feel wonderful, that's not a problem to fix. That's your body finding its balance. For adults over 85 or frail adults of any age, target systolic 140 to 150, diastolic 70 to 85. At this stage, fall prevention is the priority. A fractured hip at 87 has a devastating prognosis. Blood pressure of 145 over 82 is unlikely to cause a stroke in the next few years, but a fall could end independence tomorrow. Quality of life and function matter more than hitting a specific number. For older adults with diabetes, heart disease, or prior stroke, target systolic 130 to 140, but with careful individualization. These conditions do increase cardiovascular risk, so lower pressure provides more benefit than in healthy seniors, but going below 130 still increases fall risk. The sweet spot is usually 130 to 140 with close monitoring. For older adults with chronic kidney disease, target systolic 130 to 140, carefully monitored. This is complex. Moderate blood pressure reduction can protect kidneys, but aggressive reduction can reduce kidney perfusion and worsen function. Individual response varies enormously. Critical point for everyone. Diastolic pressure, the bottom number, should generally stay above 65, ideally 70 to 85. Very low diastolic pressure reduces blood flow to your heart muscle during the relaxation phase. Diastolic below 60 is concerning at any age. Below 55 is dangerous. Dorothy's standing diastolic of 48 meant her heart wasn't getting adequate blood. This contributed to her collapse. Comment which category you fall into. 65-74 healthy or 75-84 diabetes or over 85 frail. I want to see who's watching and help you understand where you fit. Here's the most important thing I can teach you today. More important than any target number. You need to check yourself for orthostatic hypotension. This is the hidden danger that killed Dorothy, and your doctor probably isn't checking for it. Here's how to do it at home. Step 1, get a reliable home blood pressure monitor, the automatic arm cuff kind. They're accurate and easy to use. Step 2, lie down flat for 5 full minutes, relax, let your body settle. Step 3, while still lying down, check your blood pressure. Write down the numbers. Step 4, stand up. Immediately check your blood pressure again while standing. Write down these numbers. Step 5, compare the two readings. If you're systolic, top number drops by more than 20 points, you have orthostatic hypotension. If your diastolic, bottom number drops by more than 10 points, you have orthostatic hypotension. Example, lying 134 over 78, standing 108 over 64. That's a 26-point systolic drop and a 14-point diastolic drop. Significant orthostatic hypotension. This person is at risk for falls regardless of what their lying blood pressure looks like. What to do if you have it. Bring these numbers to your doctor. Show them the lying reading and the standing reading. Tell them you're concerned about fall risk. Most doctors only check blood pressure sitting. They never see the standing drop. They never know the danger exists. You have to advocate for yourself. You have to bring them this data. If you have significant orthostatic hypotension, your medications likely need adjustment, even if your lying pressure seems perfect. A lying pressure of 118/72 means nothing if your standing pressure is 84/52. You're going to fall. It's only a matter of time. Here's the complete protocol for working with your doctor to find your optimal blood pressure. Step 1. Home monitoring. Check your blood pressure at home twice daily for 2 weeks. Morning and evening, same time each day. Keep a written log. Home readings are more accurate than office readings. No white coat hypertension, no anxiety spikes, just your true baseline. Step 2. Orthostatic testing. Do the lying to standing test I just described. Do it 3 times over a week to make sure your results are consistent. Step 3. Symptom inventory. Write down any symptoms you're experiencing: dizziness, fatigue, mental fog, difficulty concentrating, weakness, unsteadiness. These symptoms might be blamed on just getting old, but they might be from blood pressure that's too low for your body. Step 4. Medical history review. List all your medical conditions: diabetes, heart disease, prior stroke, kidney disease. List all your medications, including doses. Step 5. Doctor conversation. Bring all of this to your next appointment: your home log, your orthostatic test results, your symptom list, your medication list. Have an honest conversation. Say, I've been reading new research suggesting that blood pressure targets for older adults should be higher than 120/80. Given my age and my symptoms, can we discuss whether my current target is appropriate for me? Most doctors will listen. Most will consider adjusting targets when presented with evidence and your personal data. If your doctor dismisses you without considering your symptoms or your orthostatic test results, consider a second opinion. Step 6. Gradual adjustments. If you and your doctor decide to change medications, do it slowly, one change at a time. Monitor blood pressure frequently during the adjustment period. Watch for both improvement in symptoms and for any new problems. Step 7. Ongoing reassessment. Your optimal blood pressure might change as you age. What's right at 70 might not be right at 80. Reassess every 6 to 12 months. Repeat the orthostatic test. Make sure your current approach is still serving you well. Now let me address the questions I know you have. My doctor insists on 120/80. How do I convince them? Bring the research. Print out the JAMA study I referenced. Show them your orthostatic test results. Explain your symptoms. Most doctors respond to evidence combined with patient-specific data. They may not have seen this newer research. Guidelines are slow to change. You may be educating them. If they still refuse to consider a higher target despite your symptoms and your data, get a second opinion. Your quality of life matters. I'm on multiple medications and still can't get to 120. Should I add another? Maybe not. If you're over 70 and your pressure is 142/84 on 3 medications, adding a fourth might cause more problems than it solves. Ask your doctor, is 142/84 acceptable for someone my age? What's the actual risk if we stay here versus the risk of adding another medication? The answer might surprise you both. What if my pressure varies a lot throughout the day? That's normal. Blood pressure isn't constant. It fluctuates with activity, stress, time of day, food intake. What matters is the average over time. That's why you keep a 2-week log. One high reading isn't an emergency. One low reading isn't automatically good. Look at the overall pattern. Should I adjust my medications on my own? Absolutely not. Never change blood pressure medications without medical supervision. Some medications can cause dangerous rebound effects if stopped suddenly, but do advocate for yourself. Schedule an appointment. Bring your data. Have the conversation. Ask for changes if needed. Your doctor prescribes. You provide the information that guides those prescriptions. If this video gave you knowledge that could prevent a fall, that could improve your quality of life, that could save your life or the life of someone you love, share it. Share it with your spouse. Share it with your parents. Share it with every friend over 65 who's on blood pressure medications and feeling dizzy or tired. This information isn't reaching people fast enough. Guidelines take years to change. Doctors are busy. Patients suffer in the meantime. You can help fix that by sharing what you've learned. Subscribe to this channel. I'm committed to bringing you research-based information that your doctors might not know yet. Information that could change your life. And leave me a comment. Tell me one of three things. Comment too low if you think your blood pressure might be too low for your age. Comment just right if you feel good about your current numbers after watching this. Comment talking to my doctor if you're going to bring this up at your next appointment. Bookmark this video. Come back to it before your next doctor's visit. Review the orthostatic test. Review the target numbers for your age group. Bring this information with you. You deserve a blood pressure target that's right for your body, not a one-size-fits-all number designed for someone 30 years younger. Advocate for yourself. Your independence depends on it. Your life might depend on it. I'll see you in the next video, where we continue taking control of your health together.